Hello, everyone. It is a great honor to be asked to present this lecture regarding thrombosis prophylaxis for venous procedures and for patients suffering from the coronavirus illness. Here are my disclosures. Fatal pulmonary emboli are the #1 preventable cause of death in hospitalized and surgical patients. Appropriate anticoagulant prophylaxis can prevent most deaths. Risk scoring identifies who is at risk for these emboli and guides the physician choices for preventative measures. Providing prophylaxis for the entire period of risk is the key to preventing these deaths. Everyone has unique risk factors that make one prone to developing a pulmonary embolus. Obesity, cardiac or pulmonary disease, cancer, family history of blood clots or stroke, diabetes, hormonal therapy are some examples of these comorbidities. A risk score can be calculated based on these risk factors that is predictive of a thrombotic event if surgery, injury, or illness occurs. Knowing one's baseline score is an important part of their baseline medical record. Informing healthcare providers with this personal information is critical, especially if one contracts the coronavirus, experiences a disabling stroke, or requires emergency surgery. We prefer the Caprini score since it is the most comprehensive list of factors associated with a venous thrombosis, examining 40 elements in the history and physical. And we do know that as the number of risk factors goes up, the risk of venous thrombosis increases. We also know that each factor has a certain power to cause a thrombosis. Low power for things like bed rest or hormones, high power for things like cancer of the pancreas, or a blood clot, or thrombophilic defect. Now, taking the number of risk factors and putting together numerically all of their powers, we come up with a score. And this score is a simple number, and as the score goes up, the incidence of DVT goes up. And here you can see an example in general surgical patients. Since there is a lot of elements in this score, we've been fortunate to have a number of brilliant investigators from around the world develop this score in their own languages. And it's in patient-friendly terms, as you can see here. And these questions, once they are tallied, facilitate a preliminary patient-friendly form in advance of elective surgery, and this is done ideally with the help of the family members. It's very important to network with your family and ask about past history of problems, especially in previous generations, because they may be important. This form then is validated if you get admitted by the person responsible for the history and physical. And there are certain things that they can go over that sometimes are not well understood by the patient, including how to calculate the BMI, the presence of pitting edema and varicose veins, and a history of obstetrical complications, particularly important because patients with that history may harbor a thrombophilic defect. It is important for everyone to do their score ahead of time so that if something happens and they go to the hospital in emergency, especially if they have a stroke or another injury that precludes them from talking or are seriously ill, the family member can provide that information. Once the patient gets admitted, we know that to continue to update the score is critically important. Some people come in with low scores, but as the hospitalization progresses, they develop problems that could lead to increasing their risk of thrombosis, and hence their prophylactic program may need to be increased. So this is a dynamic instrument. We have to remember about the definition of certain terms. Varicose veins are bulging veins, as you can see, and we do not count spider veins. Similarly, pretibial pressure on the leg will provide an index of whether or not there is leg swelling, as well as the presence of loss of bony prominences, swelling on the foot, and so forth. I'd like to focus on immobility because this is a poorly understood factor and it's very difficult to come up with a definition. We've adopted the definition that was proposed as a result of a trial that was done in 1999, the Venous trial, in which patients from various countries who are medically ill were either given low molecular weight heparin or not. And the incidence of venous thrombosis was tabulated. And of course, the administration of low molecular weight heparin was very successful in reducing the incidence of venous thrombosis. What also was looked at, and Professor Amin did a subset analysis of this, was in those patients who were in the control group, if they could walk 30 feet, their incidence of DVT was cut from almost 20% to 10%. And it was further reduced to around 3% if they were taking low molecular weight heparin. So we've adopted this as our definition of ambulation. Now, the patients can use a cane or a walker for stability, and they still can satisfy the definition if they're using both legs. Sitting up in a chair or walking a short distance to the bathroom does not constitute ambulation under this definition. And if a person has a leg cast boot or brace that inhibits normal calf or ankle pump motion, then these patients are immobile, particularly if they have a non-weight-bearing status. Studies have shown that the flow in the leg on duplex scanning does not change from baseline if the patient is not weight-bearing. So these patients are at risk. I would like to point out to the audience that failure to account for a family history of venous thromboembolism, including known thrombophilia markers, is a potential fatal flaw in the risk assessment process. You would be surprised how often this question is not asked. We also know from this very large study involving over 180,000 patients over 25 years that there's an increased risk of venous thromboembolism in first, second, and third degree relatives. And also, there's a slight increased risk in people who live together, loved ones, and so forth. And this latter fact may be attributed to common lifestyles of people living together. The value of a family history as a risk indicator for venous thrombosis is extremely important. The relative risk increases with the number of risk factors identified. A combination of a genetic and acquired risk factor in one study resulted in a 60-fold higher incidence of venous thrombosis than for those who had no known risk factors and a negative family history. A positive family history increased the risk of venous thrombosis overall more than twofold, regardless of the risk factors precipitating the thrombosis. About 150 years ago, a famous German pathologist, Rudolf Virchow, came up with 3 factors which he said were associated with venous thrombosis. And if all 3 were present, the incidence of thrombosis was rather high. And they are stasis, or slow blood flow, vessel wall injury, or hypercoagulability. We know that during an operative procedure, that all of these factors come into play. The anesthesiologist has to give a muscle relaxant to paralyze the muscles for intubation, and that causes the veins in the leg to dilate because the muscle tone is required to keep them from over-dilating. The overdistension can produce cracks in the wall of the vein, and then hypercoagulability of the patient can occur. And that hypercoagulability is multifactorial. There are retained metabolites of normal muscle metabolism that are sitting there that should be moving out of the leg, but they're not. The patient has hypercoagulability based on their own risk factors, and especially in the coronavirus pandemic. And the time of anesthesia intensifies these effects. The use of intermittent pneumatic compression devices on the calf, the leg, and/or the foot are critically important to minimize these changes as the operation continues. Here we see a 1,000,000 power micrograph of a vein wall with the lining cracked due to overdistension, exposing the blood to subendothelial collagen. And that, as we see here, can produce blood clots in that exposed collagen, which of course can occur during the operative procedure. We also know as blood flow slows, the white cells change into adhesion molecules, as seen in this cartoon. These adhesion molecules will then slow down with a slowed blood flow, and they will actually come to rest on the endothelial wall, and an inflammatory reaction will occur as a result of extruded granules, which will damage the endothelium, create holes, and render it ineffective in transmitting blood and oxygen back and forth in the normal manner. Here we see a picture of this in actual experiment. And you can see the white cell, which is now an adhesion molecule, actually burrowing through the endothelium of the vessel. Another important factor shown here is that when the leg is straightened, the popliteal vein in some patients shuts down. And that produces a slowing of blood flow out of the leg because now the blood has to go around that obstructed popliteal segment. And therefore, it's very important to put a pillow underneath the patient's knees during the operation. And also, if you're standing up straight, like at attention, you have to make sure that the knees are slightly bent. Otherwise, the person can faint. So taking a look overall, surgical procedures that last over 45 minutes under general or regional anesthesia are considered major from the thrombosis standpoint, even though it might be a minor operative procedure from the surgical standpoint. The longer the procedure goes, the greater is the risk. The use of pneumatic compression is very important to minimize the effects of this anesthetic. And a pillow under the knees helps to prevent popliteal entrapment due to extension of the knee. Let us now talk about venous procedures, whether it be by ablation or other methods. And here is a recent survey that was done that showed that 71% of the respondents agreed that the administration of one dose of low molecular weight heparin for these procedures did not have any real effect. And there's no evidence that it's effective. And this is especially useless in low-risk patients because you can't lower the risk of a low-risk patient any further by administration of anticoagulants. On the other hand, patients who are at risk deserve a full course of therapy shown in clinical trials to be effective. That's usually at least 5 to 7 days. And very high-risk patients may need extended prophylaxis. And if you look at the pie chart above, the respondents of this survey, 3/4 of them always prescribed some prophylaxis, and then 20% of those just sometimes, and then a few of them, 6 or 7%, never. Here's one of the best studies that I've found regarding the evaluation. Here we see a study from the University of Michigan by Andrea Obi, Tom Wakefield, and Associates in 1,000 limbs done over a period of several years. These were ablation procedures with or without transilluminated power phlebectomy. And you will see in this report that the incidence of DVT was 1.5% for radiofrequency ablation alone, increased to 3.3% if you add the TIPS procedure. And similarly, you can see the EHIT and superficial venous thrombosis incidences listed here. Now, the protocol consisted of perioperative administration of 5,000 units of heparin, and then continuing that for 1 week post-op if the score was equal to or greater than 8. Immediate ambulation and compression were used for 2 weeks, with imaging at 7 days, 3 and 12 months, and then yearly. The authors stated that ablation of axial reflux with the TIPS procedure improved outcomes, and they felt it should be the first-line therapy for varicose veins and venous insufficiency. Their standardized protocol, as I've shown, gives a low incidence of venous thrombosis, and those rates were lower than the literature, comparing both RFA and also surgery. In addition, an update for the year 2019 indicates only 1 case of asymptomatic calf vein thrombosis. So the authors continue to use this protocol going forward. Here is a suggested scoring system for these patients. Most importantly are the history and family history of thrombosis or thrombophilia. Age is also an important factor, as well as BMI and cancer. And the gynecologic and obstetrical incidence. We suggest that those patients with a low score get compression stockings alone, whereas if they have a score of 5 to 8, that they get 7 to 10 days of low molecular weight heparin plus compression stockings. And those who are higher risk get a scan at 10 days in addition to the low molecular weight heparin and compression before stopping the low molecular weight heparin. We feel that 14 to 28 days of thrombosis prophylaxis for a family history of thrombosis or thrombophilia should be done regardless of the score. Now let's talk about COVID-19. We have suggested that the Caprini score have some additional modifications. So those patients who are positive and asymptomatic, we score an additional 2 points. We move that up to 3 points if they become symptomatic and up to 5 points if their D-dimer is positive. This preliminary classification has already been tested by Krolobostov in Russia, and the results are pending review, but they are very promising in terms of helping us identify risk for these high-risk patients. Don't forget that you have to take all of these scores and add them to the inherent surgical risk scores, and then update this as you go through hospitalization and at discharge. Here are the American Venous Forum suggested guidelines for COVID-19 patients. Now, there are many guidelines, 12 or 14 guidelines, and they vary. Some of the guidelines are not in agreement with others. Some are more conservative than others. And we present these because they represent a compendium of American Venous Forum members in terms of approaching this disease. We feel that all patients who are admitted with the diagnosis should receive heparin or low molecular weight heparin prophylaxis. And we'd like to say that there's 3 times when risk assessment is critical. The first one is on admission, because on admission, if the patient has additional comorbidities such as elevated BMI, cardiac or pulmonary insufficiency, or past history of thrombosis, then that dose of anticoagulation prophylaxis we feel should be doubled right from the beginning. For those that don't score an admission, you certainly want to score at discharge. And we advocate also updating the score during hospitalization. So that's the second time. The third time is to rescore the patients at discharge, where it's very, very important. And we'll discuss that a little bit more in detail. But especially those with an elevated D-dimer, BMI of over 35, limited ambulation. A lot of these patients are still weak, and they're not really able to walk that 30 feet. A lot of them have cardiac failure. A lot of them have pulmonary problems or on oxygen, and these are all very high-risk patients following discharge. We would also like to point out that patients who are operated on with a positive viral infection have some very serious consequences. The incidence of venous thromboembolism is 50%, and a quarter of them almost can die at 30 days. And 38% of them that have pulmonary disease actually die, and that represents 82% of the patients. Particularly important are males in age over 70 years, with an increase in morbidity and mortality. Now let's go back in history, and we refer to the very wonderful Riete database started by Manuel Monreal, and this was a paper published by Juan Arcelas in 2008. And these, as you know, are patients that have DVT, and their doctors put all of their data in the database. What their risk factors were, how they were treated, and what their outcomes were. Real-world data. And from that, we learned in that 2008 that 77% of people get their clot when they come home from the hospital, and 55% after prophylaxis was discontinued. And around that time, and in the next few years after that, was a very alarming trend. And that was patients were being treated in the hospital for shorter and shorter periods of time. And so they were stopping their anticoagulants when they went home. And this was a policy that was advocated by the guidelines as well. And this was contrary to the fact that we know that patients need to be treated for a period of time shown in clinical trials to be efficacious to prevent venous thrombosis. And that's at least 5 to 7 and 10 days, at least, in some patient groups. And we also know that during this period of time, the policy of the Americans with the Surgical Care Improvement Project to give a dose of anticoagulation within 24 hours of surgery was a failure. And it didn't really lower the incidence of DVT. John Haidt in 2017 published a very interesting analysis in Olmsted County where he took a look at the trends in the Mayo Clinic over the previous 5 years were such that now well over 90% now were getting prophylaxis, so it was going up and up. But what was happening is the incidence of venous thromboembolism in Olmsted County was staying the same or going higher. So obviously that strategy didn't work. And he said that further strategies had to be looked into. And I would remind the audience that reinforces the concept of using prophylaxis following discharge. And now that we have direct oral anticoagulants that have been shown to be of benefit, that is not as difficult as it was when we had to give heparin injections. We know that high Caprini scores should receive extended prophylaxis, and we also know that COVID-19 patients have a greater risk than the average medical patient. And what I don't understand is why the authorities, instead of saying that, well, there's no data to indicate that we should give prophylaxis after discharge, why doesn't somebody tell us that we have all this historical data that shows the value of post-discharge prophylaxis? We show all of this historical data that when it's not done, the DVT rate goes up. We know that COVID patients are even higher at risk than this. Why wouldn't we take what we already know and apply it to the COVID patients and then wait for clinical trials to show us whether or not we were correct? And what happens in the meantime is we're protecting all of those patients. Now, we've been talking a lot about the Caprini score because it's used in over 100 50 clinical trials in over 5 million patients around the world. But it's not the only road to Rome. There's also some other very good scores. There's the PADO score. There's the improved score. There's the improved D-dimer score. There's the Geneva score. There's the National Health Service score from England. So there are a number of different scores. And I would like to highlight that the FDA in the United States has approved Betrixaban and Rivaroxaban for both in-hospital and extended thromboprophylaxis in high-risk medical patients at low risk of bleeding. And this comes from those 4 trials of ADOPT, Magellan, Mariner, and Apex, clearly showing the value of Betrixaban and Rivaroxaban for the prevention of VTE in the medically ill in hospital and after discharge. And it is estimated now still that over 60% of VTEs occur after hospital discharge, with 80% occurring in 6 weeks. Despite all of these data, less than 4% of patients are sent home on prophylaxis, and this is pre-COVID-19. We also know that the symptomatic rate from these studies more than doubles during the first 3 weeks, and a 5-fold increase in fatal VTE events occurs within 45 days. Please score your patients at discharge. COVID-19 magnifies all of these statistics. Here we show just a simple algorithm to illustrate the points from the previous slide. And it's really very important to provide ongoing prophylaxis to these patients with the COVID-19 infection. So in conclusion, we believe that one should perform thrombosis risk assessment using your favorite tool now. Get something in the record on your chart available. Venous procedures may be at high risk, and some of them may need prophylaxis. Pulmonary thrombosis and alveolar endothelial damage are prominent features of COVID-19, emphasizing the need for prophylaxis. And arterial or venous thrombosis can occur anywhere in the body. Tailoring the use of anticoagulation is the key to success. Performing ultrasound scanning for specific indications only, and only when that would improve the care of the patient. Avoid elective surgery in COVID-19 positive patients because of the serious morbidity and mortality associated with these individuals. And finally, post-discharge prophylaxis is going to be required for most patients. Now, I'd like to thank you all for your attention to this lecture. I'll be happy to try to answer some questions. And everybody, please stay safe and have a wonderful day. Visit my website, venusdisease.com, or my YouTube site at Venous Resource Center. Thank you very much.